Okay, so this is chapter 9 in Radomski, and it's all about assessing abilities and capacities as it relates to sensation. So what is the role of sensation in occupational functioning? A lot of the activities that we do may require sensory feedback because they're totally dependent on the sense of touch. For example, holding a bottle of water requires sensation because we have to know how firm or how soft to hold it in order to not crush it. Same goes with taking a hot bowl out of the microwave. Temperature sensations allow us to realize if the bowl is too hot to carry to the table. And lastly, clasping a necklace behind your head or behind your neck relies entirely on sensory feedback because vision is occluded. So the purpose of sensory evaluation, there's so many factors that play into that. So making sure to assess the type and extent of sensory loss, evaluating and documenting sensory recovery. It assists in diagnosis. It helps to determine impairment and functional limitations. It provides direction for OT intervention. It determines a time to begin sensory reeducation. It determines the need for education or the need for desensitization. So some of the neurophysiological foundations of tactile sensation. So you have receptors for tactile sensations that are present in the skin, muscles, and joints, and they're each specialized for a single type of sensory stimulation, whether that be touch, temperature, or pain. And I included the neural pathways of sensory stimuli chart that was in Radomski, and it just has the type of sensation, what sensory receptors are being used, the type of afferent neurons, pathways, and the termination of those pathways. And then you also have the sensory homunculus, so areas like the face, the hand, and the fingers have a higher density innervation, and that just means that they're highly sensitive. And then they have a proportionately large representation within the somatosensory area of the cortex, and that can be seen on the homunculus as well. Okay, somatosensory deficit patterns, so cortical injury. Patients with brain lesions caused by stroke or acquired brain injury demonstrate sensory losses related to loss of functioning of specific neurons within the central nervous system. So their perception of fine touch and proprioception are most affected. Temperature sensation is less affected, and then pain sensibility is affected the least. And the effects of the stroke sensation also depend on distribution of blood supply. So if there's an occlusion of the middle cerebral artery, which is the most common site of stroke, it's often associated with contralateral impairment of all sensory modalities on the face, the arm, and the leg. And there's a chart with a mnemonic to help kind of remember some of the signs and symptoms. Occlusion of the anterior cerebral artery tends to cause more loss of sensation in the contralateral leg than it does in the face and the arm, just because of the supply to the medial aspect of the cerebral cortex. And there's also a chart with some signs and symptoms. And then lesions to the posterior thalamus tend to result in loss or impaired cold sensation and central pain response. Okay, and the book mentions some guidelines and planning assessments for patients with cortical injuries, so I'll just go over a few of them. So making sure to quickly screen areas of the body where sensation is likely to be intact, followed by more thorough evaluation, because you want to spend more time on areas that are most likely to be affected. If tactile sensation and proprioception are intact, then pain and temperature assessment do not need to be tested. And then if pain and temperature are absent, then assessment of light touch and proprioception are not necessary because they too will be absent. And then just remembering that pain and sensation recover before light touch and proprioception. Okay, and then spinal cord injury. So patients with lesions of the spinal cord demonstrate a total absence of the sensation in the dermatome below the level of the lesion. And then the level of the lesion determines the extent of the sensory loss. So incomplete spinal cord results in sensory losses that are related to damage within the specific spinal tracts. And so I included this chart with some incomplete spinal cord injuries. And so you have anterior cord syndrome, central cord syndrome, Brown-Séquard syndrome, and posterior cord syndrome, and then you can read that. And so some of the guidelines the book talked about in planning assessments for patients with spinal cord injuries is using the ASIA scale, which is the gold standard for spinal cord injury, making sure to apply stimuli to the key sensory points within each dermatome when you're testing, making sure to test bilaterally because results may differ from side to side, so you want to make sure to get that. And testing for multiple sensory modalities, as well as testing of pinprick and light touch for patients with complete lesions where sacral sparing is absent due to determine the zone of partial preservation. Okay, and then peripheral nerve injury. So patterns of sensory loss following peripheral nerve injury vary with the nerves involved, and damage to a single nerve root as it exits the spinal cord affects sensation on one side of the body within a single dermatome. And so the severity of sensory loss can vary pretty widely. And so I included a peripheral nerve injury classification chart, and it depends on whether you're using Seddon's chart or Sunderland's, but it goes over the types and then the pathophysiology behind it. So you can check that out. And then the guidelines it mentioned in planning assessments for patients with peripheral nerve injuries are making sure to establish the impact of the disease on the protective sensation, providing education of nerve compression and subsequent recovery, and then just remembering the recovery sequence. So it goes pain, moving touch, light touch, and then touch localization. I included some of the standardized sensory testing techniques that the book mentioned, and that's things like touch threshold, static 2-point discrimination, moving 2-point discrimination, touch localization, moving 2-point discrimination, what else? Hand active sensation test, quick dash, so things like that. And then some of the non-standardized sensory testing techniques that it mentioned, and that's like touch awareness, pinprick or pain awareness, temperature awareness, vibration awareness, stereognosis, Moberg pickup, proprioception, and kinesthesia. And so when we're recording assessment results, we want to make sure that we're documenting the type of test used, the skin area tested, and then the response. The findings are pretty much summarized as either absent, intact, or diminished. Absent describes total loss of sensation or inability to detect specific sensory modality. Intact describes normal sensation, of course, and impaired sensation is when the patient is able to detect some but not all of the stimuli, or when the perception of the stimulus is different from that of an area of skin that has intact sensation. Okay, interpretation of evaluation and treatment planning. So with decreased light touch, patients may not realize that they even have a loss of sensation. There's no effect on the motor use of the hand, and they can still identify temperatures and objects of touch or by touch. With diminished protective sensation, there's decreased motor coordination, and you can see that in some slower manipulation and dropping objects from their grasp. So when you're planning treatments, diminished or lost protective sensation or absence can indicate that the patient is at risk for injury of the affected body part, of course. And depending on the severity of their impairment, they may need to be taught some compensatory strategies, or they may be a candidate for sensory retraining. Okay, so in choosing evaluation methods, clinical reasoning helps to select appropriate sensory evaluation techniques. So diagnostic and procedural reasoning suggests that certain tests are best at answering certain kinds of clinical questions. Ethical reasoning suggests that the test should be the best available for each patient and that the practitioner has developed competence in those. And then pragmatic reasoning suggests that the test should be readily available and quickly administered. And that's all.